Hey, Noor, it's George Jallo.
Hello, sir. I think thank you very much for joining today, sir. I was just starting up my things. I think people are yet to join the
That's
program.
fine. I was just signing in to make sure it works. I think I'm ready. I'll be back in 10 minutes. How's that? That'd be great. Thank you so
Sure,
much.
sure, sir. Thank you very much. Looking forward to your lecture today. Thank you so much for joining us.
Absolutely. Thank you.
Hello, everyone, and welcome to the webinar. We are starting shortly, just in 9 minutes from now. So I'm just trying to invite everybody who's line. Just a last minute quick recall. So please share where are you watching this webinar from in the chat box, and I will be happy to see and quick and shoot a quick hello while I try to look at the setup. It gets something interesting. Zoom gets you something new every time you log in. So it's like a new surprise. They have undergone a few changes. So I'm just trying to figure out where are those new features, where we used to, work at. So if you have, and share, please feel free to use the chat box to share your questions and your comments, and I'll be happy to take up all the questions and the comments. So where are you watching this webinar from? Hello, everyone. Hello, everyone, and welcome to to today's program. As you all know, it is always a certified webinar. But today, instead of sharing a link, I would like to ask you to please share your email address by the end of the session, and I will be happy to directly email you your attendance certificate. There are a couple of, network issues in Pakistan right now. That's why I'm having a little bit of internet glitch in that way. So I'm just trying to make sure that you all have the best of the experience today, and we do not have any trouble regarding, certificate downloads and emails. That's why I request you to please share your email address in the chat box at the end of the session, and I will be happy to send you your email you your attendance certificate directly. So I hope this is a very important topic, and you will enjoy this topic. Professor George Jallo, who is considered the master in the especially in this topic. Okay. Oh my God. This. Sorry, sir. I believe there's some setting issue here. Yes, sir. Can you?
Yes,
Hi,
thank you.
sir.
Hi, Hi, Nora. Thank you for that.
No, no, no. So thank you very much. I think I was just checking the final touches in the webinar settings. So somehow I forgot to make you the co-host. So now you have all those controls the host has on Zoom meeting. So, sir, actually, we are right now in Pakistan. We have the Basant Festival. It's a festival of kites. So, due to this, we are having a lot of surveillance and security in the city of Lahore, and there are a few network glitches right now, and that's why I think many of our attendees are having issues in logging in the meeting as well. So I'm really sorry about it, about all the inconvenience.
Oh, no, no worries. It's a pleasure to be here, and hopefully it's a good celebration locally.
Yes, it is. It's slightly risky because the wire that people use for kiting is quite, risky. Sometimes people get a lot of injuries around the neck region, all these things, the vascular injuries. And that's a huge issue in Pakistan right now. Our government is trying its best to, control all those accidents that might take place, but we are a little bit concerned. And so things are they are good, and um, the doctors are a little bit concerned from
Yeah.
our more surgical point of view. So again, thank you very, very much, sir, for joining us today and for your time. You are such a huge master, a legend, and also I know that you are a very, very busy neurosurgeon. So it means a lot to us that you spare your time for teaching. You are such a big inspiration.
Well, no, thank you. And it's a pleasure for me to be here today. And really, I do want to just share my experience with Chiari malformations in children. I'm going to see if I can, let me just get my presentation up. And I'd say um, it's my thoughts on Chiari malformations has really been evolving. I remember when I was in training 30 years ago, and I can tell you, I now do I don't do cures the same way I was taught to do them when I was a trainee during my residency and my fellowship in New York City. And hopefully, I'll just share some highlights and some thoughts on the management of Chiari malformations in children today. So I do want to thank you for inviting me, and I do want to welcome all the participants. If there are questions, please just ask them along the way, put them in the chat. I will try to get to them during the talk or at the end of the presentation. So, I think, but, let's discuss, really the Chiari malformations, Arnold Chiari malformation. It was really Hans Chiari, who's an anatomist in Prague that identified was the original descriptor of this malformation. And then, I think Arnold associated his name with it as an Arnold-Chiari malformation. And the definition really that they noticed, being anatomists or pathologists, was the elongated portion of the cerebellum, the tonsils, extending nearly to the top of the atlas. However, in some cases down to C2, but never, below C2 or the level of the third cranial nerve. What's interesting of these early report descriptors, it was an anatomical description, was honestly that they there were no clinical symptoms associated in their series of Chiari malformations. So I think honestly, it's we've come a long way. Besides recognizing it as a anatomical entity, it's a clinical entity that presents both in children and adults. So I think really it's just a caudal descent of the cerebellar tonsils into the cervical spine. You can see in that artist's depiction right there that you can see that cerebellar tonsils going down through the foramen magnum, causing an obstruction of the CSF pathways. And in my experience with a Chiari 1 malformation, the majority, I'd say 90-95%, are above the level of C2 at some point. I have, it's been the exception where I've seen them descend below C2, at C3 or below that for Chiari 1. Now, for Chiari 2s, that's a very different, a different disease process and entity. And as I said, there's no associated open spinal dysraphism as you would presume with Chiari 1. That would make it a Chiari 2 malformation. Hydrocephalus it can be present, although in a very small percentage of cases. And then, there are some anomalies at the skull base, whether it's basilar invagination, the clivus, and or some other anomalies that are associated with the clivus. Radiographically, and I will in the next slide show the original paper, but here it is. The MRI is the gold standard, and what you see is the tonsils below the foramen magnum here. This one's at the level of C1, and there's a presence of syrinx, and that's what is seen. It can be seen anywhere in 50 to 75%. I think every series is a little different. Some report as high as 75, and I'd say in my practice of the children I've taken care of, I'd say syrinx was present in maybe 36 or 38% of the children I have managed, although the literature is evident there. And sometimes, scoliosis is present and it could be a result of the syrinx. Other times, you can see Chiari without the presence of a syrinx but presence of scoliosis. And I'll share one such case today, and just to get some thoughts. You can see here the normal position of the tonsils and in both the normal cardiac rhythm, systole and diastole, where there's flow of CSF on with the arrows. And in the image below, you can see it with the Chiari, where the tonsils have herniated through the foramen magnum. You can see during systole the downward pistoning of 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 the tonsils, obstructing the fluid pathways and pushing the CSF through the spinal cord to create that syrinx. And in the diastolic phase, there's a slight ascension of those tonsils there. Here it is. I think this is a post-mortem study of an adult really that had a Chiari, and what you can see is the cerebellar hemisphere, the tonsils, and you can see that the right cerebellar tonsil has herniated out through the foramen magnum there, and that's not atypical where the tonsils don't symmetrically have to go down to the same level. And by definition, radiographic definition, it's as long as if they're below 5 millimeters, that it will that can lead to the diagnosis of Chiari. So, I'd say the majority of the time, the tonsils, the right and left tonsil don't descend equally. One may be lower than the other. And honestly, in some cases I've operated on, one tonsil, one is in normal position, whereas the other has significantly herniated down through the foramen magnum. So I was looking at the literature, and this is the first paper that in terms of the radiographic definition of the cerebellar tonsils. And this was in the 1980s, I think 1985, in the in the radiological literature, and really the Journal of CT, computer assisted tomography, just with the advent of MRI technology. And you can see that, they looked at a population of I think it was um, close to 90 patients, and what they found was that in a small subset, uh, what they would consider a Chiari malformation, and what they defined it as is that the cerebellar tonsils are normal when they lie at or above the level of foramen magnum. Cerebral ectopia is when they can come down to about 3 millimeters below. But the diagnosis of a Chiari is made when one tonsil or the tonsils descend 5 millimeters below the foramen magnum. So they define the borderline as somewhere between 3 to 5 millimeters. And that was their radiographic definition of a Chiari. And that's what we've hung on to that classic definition. I'm going to just turn and talk a little about the natural history. I think, we don't know that, largely unknown what happens to these children that may have an incidental Chiari. And I can tell you, I follow many with incidental Chiaris. And there's some evidence, and I will say I've had some patients that I've watched that I've made the radiographic diagnosis, but no clinical correlate of their symptoms, and we've observed them. And I would honestly say that tonsils have ascended as that child aged. So, I think, I think, yeah, if are no clinical symptoms, um, eh, these are the children that can be watched. Now, they may have no clinical symptoms, but if there is a syrinx, to me, that is radiographic demonstration of potentially clinically significant Chiari. And this recent paper back in 2021 from DC Children's really looked at, it was probably the best paper that looked at the long-term outcomes of children with an instantly discovered Chiari malformation, and what's the significance if you see it on imaging. And when I say imaging, it's really the MRI scan. And what it was it looked at children less than 18, and they looked at 218 children were enrolled in the study, and the follow-up was close to 4 years. A minimum was a year. I think the longest happened to be close to almost 9 years in terms of follow-up. And that the majority of these, a majority of these were found, I think they're related to some seizure, some trauma, or some developmental delay, or some non-specific headache was the reason for the initial imaging studies. And what they did find that, that only less than 20% required surgery during the follow-up period. And the reason for that is, the children that required surgery are the ones that were incidental findings, but there's a presence of a syrinx. And you can see that in this chart that from the time of the diagnosis, if there's a syrinx, many of these children required surgery, whereas it's a very small subset, less than 10%, if there's no syrinx, did require any surgery. And then someone's going to say, well, what if the tonsils had descended, below C2 or below C1? And they looked at this. They looked at if it was 1 centimeter below, less than a centimeter or above a centimeter. And you can see that really there was no statistical significance in the long term between the degree of herniation. So if it was, somewhere between 5 to 9 versus more than 10 millimeters. So clearly that the majority of incidentally Chiaris can be managed conservatively, especially in the absence. 16% had surgery, and those were the ones that had the syrinx. And what it is I don't think one can say that, oh, just, if you don't have symptoms, let's just you never need to come back, because there's a small subset of children that have a Chiari that may develop a subsequent syrinx. And if that develops, that's going to lead to some surgical intervention. So, again, here, incidental Chiari, the take-home message is that take-home Chiari, no syrinx, really just needs a follow-up without conservative management and no surgery. Incidental Chiari with a syrinx, you're more likely than not to advocate for surgery, because those are the ones that will go on to progress or develop progressive symptoms. So I think, the question really is, when does the Chiari in a child become surgical disease? And this is children, because I think adults are very different. I'd say not even an animal, a beast in terms of management. I think, in a international survey of neurosurgeons, really the ones that became surgical disease are the symptomatic Chiaris, the ones with symptoms, the ones that, that some advocate if there's loss of CSF at the craniocervical junction, the appearance of a syrinx, and the tonsillar descent that was below centimeter plus. But I think this recent publication showed that really the descent did not matter. And then can a Chiari be treated by cervical medullary decompression surgery alone? Um, I think, I think simple ones, yes. I think the complex Chiaris, that's not necessarily true, because we're learning more and more on the best management for these complex children that may have a Chiari, not just a simple Chiari itself, but really that you have to tailor the approach. Symptoms, I think, let's address the symptoms. What are the symptoms? I think, I break them down into three different categories. I look at it as pain or the headaches. For me, it's occipital, neck, or shoulder headaches, and that's typically can be seen in up to 2/3, and that's the classic. It's got to be an occipital or high neck cervical pain that is precipitated by Valsalva. To me, that is the classic Chiari headache. Frontal headaches. I'm not a believer that frontal or temporal headaches are related to Chiari malformations personally. The motor deficit, I think that can range from, a unilateral deficit to profound quadriparesis. And I've seen the spectrum. I've seen patients develop significant quadriparesis because of the syringomyelia slash almost the syrinx extending all the way up into the medulla and as high as into the pons from a Chiari. And I've also seen, the feeding difficulties in children. And then the other really is the cranial nerve and the I'd say brainstem signs of what central apnea, swallowing difficulties, and the likes of multiple cranial nerve deficits. But I think, clearly, one of the signs that I looked at is when I'm assessing young infants for Chiari's is to rule out a central sleep apnea with a formal sleep study to ensure that they are indeed asymptomatic. The other is, I think, Atul Goel, I mean, who's, a recognized authority, in this paper, this editorial, and says, we do call it a malformation. And is that really the true, is that the best terminology for this? And really, because it's not a malformation, it's really a formation or a deformation rather than a malformation. Because a malformation is something that children are born with. And we know and we are aware that there are many instances that these children do not have a Chiari at birth, but then develops later in life. So I think we have to recognize that as I was alluding to, these are malformations or structural or anomalies that occur during in utero, and that should be present prenatally, but we don't appreciate a large percentage of Chiari-1 malformations on prenatal ultrasounds, whereas a deformation, on the other hand, is a process of deforming and distorting. So should it be a deformation rather than a malformation? I think that, the controversy is out on that. Hopefully everyone has access to their smartphone. I just want to share this case and gather your thoughts. This was a young boy that I saw, I think, about in the summer. He was seen by his orthopedist because on a routine school physical, as he was enrolling in school this year, they noted scoliosis. The orthopedist, given the young age, obtained the MRI and then referred him to me. And you can see here the large syrinx and the Chiari. It's almost could be classified as a Chiari 1.5 on that sagittal. And neurologically, he was intact besides the scoliosis curve and some slight diminished reflexes, completely intact. A really adorable child, no deficit running around, no headaches, no swallowing difficulties. So ideally, let's see if I can get this uh, to um, to work. And if you can scan that or just enter that number, you want to know, what would you recommend to the family? Would you just continue to observe them? Would you do a posterior fossa decompression with just the bone only decompression, or would you do a posterior fossa decompression with a duroplasty? And if not, the other. So, if you all can take a minute and just scan that or enter that, text that number and just enter your response. I'd love to see what the group would think in this poll. I hope it's working.
I hope everyone can see it very well in the devices. It's quite
You know,
simple. So, yeah, exactly. Just a QR code scanning.
I'm sorry.
So I think it's quite user friendly, just a QR code scanning. But some people are putting the answers in the chat box as well. I can see it.
Okay, that's great. No, that's good. I think we'll do that. Wonderful. Posterior fossa with theraplasty. I like that. Just again, I think, thank you. What I'm going to say is just we'll I'm gonna just for time's sake, I will move on. Um, and I'll answer that question after this case. Here's another case that I took care of a year ago. She was a 14-year-old girl that presented with neck pain and scoliosis. She went to the emergency room and they did this CAT scan on her. On the CAT scan, I mean, the astute radiologist said question of a Chiari and a syrinx. So an MRI was obtained, and lo and behold, there's the Chiari malformation that you can see, the syrinx, and you can see it there. It's a focal syrinx from about C2 down to about C4, C5. And the syrinx is about 50% of the spinal cord. And again, this is another case. This young girl I took care of a year ago. and I do have follow-up. So, I mean, I think, she came to the clinic, and again, what would you recommend doing? Just observing posterior fossa bone-only decompression, posterior fossa duroplasty, a syringo subarachnoid stent. Both children did not have tether cords, by the way. I apologize for not saying that. We had entire neuroaxis imaging. And I wonder if you want to answer in the chat box, or 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 that. Okay, great. I'm gonna just move on. So this girl, honestly, I did a this was the pre-op. I did a posterior fossa decompression bone only 1 year ago. And, she was in the hospital one day, did great. And then, the question is, when do you repeat the scans? In my practice, I typically do the MRI 3 months after surgery, and then obtain another one at 1 year because I would like to see the syrinx decrease in size at the 1 year mark. So that was the pre-op. And then I saw her back recently, and that is her post. That is her 1 year image following a posterior fossa decompression, bone only, no duroplasty. So clearly, the bone only decompression was very adequate for her. And I've just elected to follow her. I plan to see her next year with another imaging, and then I'll probably space out the imaging studies. Now, that previous young boy, the 5-year-old boy with that large syrinx, if we can go back to, let me see if I can go back. Um, I'm going to just tell you, um, for him, um, because of the large syrinx and the degree of scoliosis that he had, being given that he's already at 35 degrees, I was worried that, rather than waiting a year, would prefer a more immediate response. So I did the posterior fossa decompression with duroplasty 3 months ago, and I am seeing him on Monday with an MRI to see how the syrinx has resolved. He did well with the operation, no new symptoms, and he's been doing well. So I am very curious to see, and hopefully I can give you some follow-up afterwards that with the duroplasty here that his syrinx has resolved, and we'll see what happens to his scoliosis curve. Does it stay at 35 degrees? Does it get a little better, or will it continue to progress that he's going to require surgery on his for his scoliosis? So I think, for me, this is it. I think I look at Chiari. Is it symptomatic? I exclude hydrocephalus ventral compression, exclude tether cord. Is there a syrinx? Is there a syrinx? Is there no syrinx? If there's a syrinx, I do go on to Chiari. If there's no syrinx, what is the degree? If it's less than 3 millimeters, I observe. I think 3 to 5, really clinical judgment. If it's more than 5 and they're symptomatic, then I would plan on doing the Chiari decompression. And I want to say this is my paradigm, whether it's a Chiari 0, Chiari 1, or Chiari 1.5, regardless. And I think what is the goal? It's really to reconstruct the cisterna magna, reconstitute CSF flow, and if there's a syrinx, improve or decrease the size of the syrinx, and then allow for some cranial scent of the hindbrain verified by follow-up MRIs. So, I mean, there are many operations, and I think it really depends upon your preference. And there's no one that can say their procedure is 100% cure or foolproof or complication free. So, you can do the posterior fossa decompression bone only. You can open the dura, leave the arachnoid intact. Open the dura, open up the arachnoid. You can open up dura, open up the arachnoid, and some people leave the dura open. Others will open up and do the duroplasty. Others will resect the tonsils. Some will coagulate the tonsils. Everything. Some now there's a recent paper I'm reviewing that looks at minimally invasive with just C1 laminectomy with tonsil resection and duroplasty. So I think, at the end of the day, the goal is to make the posterior fossa larger, and ideally, you're going to have to remove the arch of C1, and the incision's usually a midline incision. If I do, my practice, my foramen magnum decompression is somewhere between 2 to 5 centimeters in width and in height. I don't go, some used to advocate from transverse sinus up to the torcula. I don't, I've only seen that lead to complications. I typically open the dura in a Y-shaped fashion. You can see here after it's been opened, the cerebellar tonsils, the arachnoid is preserved there, and then I will coagulate the tonsils. And then I tend not to resect the tonsils. I'm more of a cauterizer, just with the hopes of preventing adhesions and or obstruction of the outflow from the fourth ventricle. I think there are some classic papers, especially that came out of the Picori study, the from in the United States that looked at posterior fossa decompression with and without duroplasty. In this meta-analysis, what they found was that posterior fossa decompression with duroplasty has a lower risk of reoperation than bone-only posterior fossa decompression, 1% versus almost 13%. But as it's expected, if you open the dura, you're going to have a greater risk of CSF-related complications, almost 20%. So, 1 in 5 children that you do the duroplasty will have some complications, whether it's aseptic meningitis, pseudomeningocele, or protracted course. I think this meta-analysis said there's really no difference between the syrinx size, although in my experience, I find that the duroplasty does improve the syrinx much better. And this was in the Park Reeves consortium. They looked at what they looked at was patients that had autologous duroplasty versus synthetic or non-autologous. And this was really almost a series of 800, and they had about an even number, 400 of an autograft versus a an allograft. The non-autologous could have been bovine pericardium, but collagen, a synthetic material, or some, cadaveric allograft. And what they found was that the complication rate was similar with both. But in terms of where there was that, with the autograft, the pericranium was less likely to lead to pseudomeningocele formation as compared to the allografts. And the other points were the risk of aseptic meningitis was higher with the allografts rather than the autograft in this large series. And when they looked at it, looking at the different materials, is what they found was that the synthetic one was more likely to cause a higher risk of aseptic meningitis versus the other dural substitutes. And overall, in terms of other pseudomeningoceles, hydrocephalus instability, there was no risk. So, I think there is a difference between autografts versus allografts and synthetic versus the other materials in terms of the overall complications. So I think one should recognize that in their practice of taking care of these children. I think, this really, again, looked at, from the Park Reeves, they really looked at 700 patients where they did a posterior fossa decompression versus a posterior fossa decompression with duroplasty. And what they, as classic, your posterior fossa bone only is going to be less time, less blood loss, shorter hospital stay, and fewer post-operative complications. And this is the largest study that I'm aware of to date, really that the posterior fossa duroplasty had better symptom improvement and a better reduction in syrinx and lower rates of revision surgery, and that their complication rate overall at 6 months was the same. And essentially, that is, you can see that the operative times that, the duroplasty essentially adds another hour to the hospital stay. It will increase the blood loss, not necessarily in my practice, but that's it. But clearly, the hospital stay goes, from 2 days, really in their say 3 days to about 5 days. The risk of hydrocephalus, no difference. Revisions, you can see that there are more revisions in the posterior fossa group, bone only versus the duroplasty group in that series. And I think this really, the facts here is it's summarized. I think that one has to recognize if one's going to recommend duroplasty versus just a bone only decompression. I think there's other techniques. I'd be remiss. This is, Garesh Solanki from Birmingham, advocating for posterior calvarial vault expansion with distractors for a subgroup of children that may have a Chiari malformation. I typically, it's not a routine practice for me, but when you can see there the results with the expansion and the clear improvement in the Chiari malformations in their series. And then Atul Gul's belief that, again, the Chiari is not a malformation, but a deformation, and that really it's that we should be treating them with atlantoaxial fixation rather than a decompression surgery, and that it's an element of instability and rather than a small posterior fossa. And he classifies them, he's got his three types of classification, and that using this the fixation that it does improve without having to open up the dura or do the duroplasty. So I think, the fiction is really the technical details of the operation are really up to the surgeon's preference, and that the literature supports outcomes for every surgical permutation, and there's no consensus as to what the best technique is for these. And I think, what we need to know is the fact that pain improves, yet some headaches will persist, that the recurrence of mild symptomology may not be severe to justify revision surgery in almost a fifth of the operation of the children we take care of, and that headache is more likely to recur than some of the more objective findings, and that weakness we stabilize it but do not improve it, and the cerebellar improvement is greater than 80%. This is a paper that I wrote about 17 years ago, looking at the recurrence of symptoms after Chiari decompression, and essentially was the publications. This was another paper that was in World Neurosurgery that looked at 1,300 patients, two-thirds that had syrinx. And it was a meta-analysis, and they looked at bone-only decompression, duroplasty, tonsil coagulation, and shunt procedures, and the outcomes on both the syrinx as well as on the clinical symptoms. And you can see that, that clearly there was a slight preference, as we had heard with the Park Reeves. So, as I mentioned, looking at the symptom recurrence, they can recur. And what we found was that mild symptoms that aren't severe enough do not warrant a revision surgery can occur, and it's really the headaches that tend to recur following surgery. And a lot of these headaches, that if there were atypical headaches were the ones that were going to more likely recur after surgery than the classic headaches. And I think this recent paper from the Boston group actually confirms our findings that, in terms of the headaches, there's no difference with regards to the management. But what was seen is that in the short-term headache, the ones with surgery and a Chiari, if they're classic headaches, they improved in 80% versus the ones that were not treated, and that you really have to focus on the classic findings of the headaches to treat it. So I think I'm going to just begin to close and really try to bring it all together. And here's the algorithm that I think we started with is, you've got the Chiari malformation. If it's asymptomatic, no syrinx, I will observe. If there's a asymptomatic syrinx, I would recommend circumvented decompression plus or minus the duroplasty. It's the surgeon's preference. if they're symptomatic, rule out hydrocephalus, rule out ventral compression, rule out craniosynostosis, rule out tethered cord. If there's still symptomatic, consider, other ways, whether it's, they need a reduction in invagination, fixation, cranial vault expansion, and or other findings. So hopefully, I think, if there is, as I conclude ventriculomegaly, I would treat that first, consider an ETV if there's high brain herniation progression. If it's supratentorial crowding, I'd follow that. Posterior vault augmentation, bachelor invagination, should that be treated before the Chiari? And if there's the distal syrinx, you rule out the tethered cord or the lipomas before addressing the Chiari or the syrinx. And in terms of syringomyelia, typically the syrinx is in the cervicothoracic, and that I think it's a result of the obstruction of CSF pathways. Distal syringomyelia or hollow cord syrinx, make sure that there's no tethered cord or neurulation abnormality prior to that, and that just a distal syrinx one should address. And I think that is it. Hopefully, I've shared my thoughts on Chiaris with syrinx in children, and hopefully it answered some of your beliefs and some of your questions. I'm going to look. I think, do I advocate for C1, C2 fixation? I think there are. Um, Doug Brockmeyer in the Utah group came up with some angles that one measures in terms of occipital cervical angle. There's and several, McRae's lines and all that, and felt that, if they met the criteria, that they would warrant a decompression and infusion. I would say, in my experience of, I'd say, close to 400 Chiaris, I've only done a fusion upright outright fusion twice, where we've done a little decompression and fusion. Otherwise, I'm always doing the decompression first, and before I consider a fusion procedure.
Thank you very much, sir. It was a wonderful talk. It was a very good, insightful talk. I think everyone must have really benefited from your wonderful experience that you have very nicely compiled in a few, you have very nicely clarified everything, every nuance possible that in Chiari malformation. So we do have a few questions over here, but sir, there is also a couple of things like when we talk about in patients who undergo technically adequate posterior fossa decompression checked, they have persistent syringomyelia. So how do you interpret it is as a failure? Whether it is, primary, how will you basically differentiate whether it is a primarily residual CSF flow obstruction, or do you think that there could be an intrinsic spinal cord factor like chronicity, like compliance issues or gliosis placing limits on syrinx reversibility? So how do you think about that?
I mean, that's a great question, Nora. So yeah, I will do the decompression and follow the syrinx. In my definition of a syrinx failure is at a year if it hasn't decreased in size. Do I want, and when does it decrease? It does have to be smaller by 50%, 90%. To me, if I do a decompression, whether it's a bone only or a duroplasty, if the syrinx is smaller than it was preoperatively at the 1 year mark, I am satisfied and I will watch it. If it doesn't go down, I will then advocate for a re-exploration to ensure that there are no adhesions, outflow adhesions, at the level of the fourth ventricle. And I will tell you, I've seen some, both in some of my cases and others where, the syrinx doesn't go down, and then there's an outflow obstruction at the level of at the at the outflow of the fourth ventricle at the foramen magnum. And that's where I would advocate for lysis adhesions and possibly a stent placed. Now, some of the Boston group, Mike Scott, always did, coagulated tonsils would always put a stent in. I am not a believer in that, only if there's, what I would consider a failure. And again, I think you really have to rule out is, if you're going to go back in, make sure there's no indolent hydrocephalus, there's no tethered cord again before one explores. Now, I'd say there's been some where I've explored them and there still hasn't been resolution in the syrinx. And that's just a handful. I can count them on one hand where I've had to do a syringeal subarachnoid stent. And I reserve that. Now, remember, I said I've changed my practice. When I was in New York and I trained with Fred Epstein, we did all for Chiaris with syrinxes. We would posterior fossa decompression, duroplasty, and we did syringeal subarachnoid stents on every child up front. And that's how I trained. But I'm not a believer now, as you can see. And then I only did posterior fossa decompressions with duroplasties. And then as I've gotten older, I actually now believe for some children that a posterior fossa bone only decompression is good, as I shared in that second case. So I don't think you can be dogmatic and just have one approach. I think it's got to be tailored to that individual child.
So regarding neuroplasty, you have raised a wonderful another point. It's a very nuanced point that how do you conceptualize neuroplasty? Do you think it is primarily as a CSF flow restoration step or the compliance modifying intervention? How do you actually visualize? How would you like to conceptualize neuroplasty?
So for me, if I do the bone only, I typically use the ultrasound to ensure that there's good decompression and
Good.
there's good pulsations. And if I feel that, then I'm going to just do the bone only. If I do the duroplasty, the other is I am an allograft person. I use synthetic, and you can clearly see that's probably not the best choice from the Park Reef study. But I'm a synthetic person rather than using pericranium or some other, autograft. Um, and I'd say my complication profile is small. So again, I think for me, it's reconstituting that CSF space.
That's great, sir. Sir, also, there are a couple of things that do you think that there is any certain age group according to which you might, choose duroplasty or no duroplasty, any other factors like modifications or the anatomy of the patient? What would you
Oh,
depend on that?
honestly, if I don't, I mean, I prefer not to do a duroplasty in children less than 2 or 3 because, their dura is hypervascular. They've got occipital sinuses. So, if I can get away with a bone only in the young children, to me, I'm always favoring 3 and under. I'm always thinking bone only if I can. 3 and older, depending upon duroplasty versus not. But I think, if you can get away, as I said, the bone only is a simpler operation, less blood loss, shorter hospital stay, less complications. And that's amplified in the younger children and the babies, especially so.
Well, that's great. So there's also, some sort of also a debate on the existence of BIH or the IIH, that's the benign intracranial hypertension, also known as idiopathic intracranial hypertension and coronary malformation. And sometimes there's a pseudo coronary secondary to, the BIH or the IIH, whatever people would like to call it, benign intracranial hypertension or idiopathic intracranial hypertension. And sometimes there is speculations that obviously there might be a coronary malformation coexisting with benign intracranial hypertension, and also there are misdiagnoses. Sometimes people consider it as a coronary malformation, and there is actually BIH that the patient is suffering, and sometimes that's why the results are not there. So, do you think what's your line of action between how to differentiate the BIH and the coronary malformation, and in case there's any misdiagnosis?
I didn't even address that, and I'm glad you brought that up. That is a very complex, differentiating, intracranial hypertension from a Chiari, and I think you really one needs to do that. If there's, there's a subset, if it's a female, slightly overweight, and has a Chiari, I automatically get, an ophthalmological examination to rule out papilledema. If there's papilledema, then I'm going to be worried, more concerned that intracranial hypertension. Also, the headaches are different, right? If they're frontal temporal headaches, to me, that's not the Chiari. It's probably the intracranial hypertension.
Exactly. And so also there's another very common question that people usually like to ask is the sign MRI. Do you believe in the sign MRI that could be helpful in some borderline cases or cases like
Uh,
a zero coverage?
You know, it's funny you asked that. I was a strong advocate for doing the Cine flow studies on all the MRIs for Chiari's. Uh, and I don't think it was helpful. It's funny. We wrote a paper when I was in Baltimore that in terms of Cine, it was if there was an obstruction of flow anteriorly uh, on the pre-op, they were the ones that were going to improve more than the ones that had a posterior flow obstruction. So for me, I do the cine to confirm if I don't want to operate on someone. So they've got some cerebellar, the tonsils are low, they have vague symptoms. I will do a flow study to document that there's good flow CSF in front and back to tell the family, there's no reason to operate because they're not going to get better.
That's wonderful, Sarah. I have actually read your paper on today MRI myself, so that's why I was a little interested to put this in the chat because we have got a lot of audience and many of them are young neurosurgeons. So I try my best. You have you have delivered a very elaborate lecture. I think we do not have any more questions to add to the discussion because you have already answered several of these in the lecture. So there is just one question in the audience from the audience. My question to Professor Jallo is syrinx at C5, C6, and urinary incontinence without any Chiari in a patient of 10 years of age. What's your management?
I
Just
think
syrinx.
Yeah, that's I see that we see that all the time. So for me, one, we get referred for syrinx and some, urinary or const bladder or sometimes constipation. One is how large is the syrinx? If it's a small syrinx, I don't think there's a relation. For the larger syrinxes, is it truly the bladder? Is the bladder dysfunction related to it? I have to admit, in my practice, I've only stented one syrinx, and it was a very significant large syrinx. No evidence of Chiari, no evidence of tether cord that presented with bladder. I think I do a thorough assessment, looking at getting urodynamic studies and all that to help document if there truly is dysfunction. But I am not a strong believer in treating syrinxes. Um, uh, 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 because I'm not I don't fully understand if they're related to some of the presentations that these children come with. Hopefully that was clear.
I believe so. So thank you very, very much. Your
No,
answers are already very much elaborate and very much insightful. So I think, sir, you have almost touched every aspect that we could think of in Chiari malformation. And um, there are so many compliments and so many thanks for you. So several of our attendees have sent a lot of thanks and a lot of appreciation for your very, very insightful lecture. So, sir, thank you very, very much again for your time. We have taken much of your time today in
thank you.
discussion as well.
Thank
Thank
you,
you
Noor,
very,
and
very
good
much.
luck, everybody. Enjoy the weekend. Thank you. Bye bye.
Sir, thank you very much. Bye, sir. Thank you very much. Thank you all for joining today. I'm just going to copy and paste your email ID somewhere so that we can actually I can actually send you. Um, can you please send your email IDs? That will be helpful for the certificate because today I'm actually not using my not using the other link because of I had some network issues. That's why I was trying to make sure that everyone gets their certificate and an email. So I will send you the link in the email right now because of again some network issues. Thank you very, very much for liking it. I hope you all liked it. So as you all know that I also work for the ANS CNS joint section for tumors. So, and we are going to have some wonderful talk with Professor Michael Sucre on network-based tumor surgery on 19th of February. Please do join us. I will be sharing the details of the meeting in my groups and also on my social media. Please don't forget to join that meeting. I hope you will all like it too, because that's going to be one of the most wonderful meetings of all times. And I hope you all I'm not missing out anything. Thank you very much, whoever is saying thank you. Thank you all. I hope you all know about my news network and my news social media platforms and the group that run for the news. So, oh, thank you very much, Dr. Noyako. Thank you very much, Dr. Joseph. Is there anyone left who has not sent me their email address? If so, please share your email address so that I don't miss out anybody. Thank you very much, Dr. Bakit Khan. Thank you very much, Dr. Kingsley. I'm so happy that you all liked it so much. I'm so happy to have to see you all here. I try my best. All of our, speakers are the most famous, and they have, the best knowledge and experience on the topics they share with us. And I try my best to bring out several of the topics that I believe could be of interest for all the viewers, especially the young neurosurgeons. So I try my best to bring out all the questions, all the possible questions that the young neurosurgeons might be looking for. Because, when I was myself a resident, all these things were a lot, important. So when I go back and think about that, I just try my best to make a list of all the possible things that people might be thinking about or might be, searching answers to. So I try my best to keep to bring out those topics during the discussion, during the Q&A. So in case if everybody has anything to add, please feel free to share the questions in the question box. I try my best before the program. I try to make a list of all the possible things that you might be thinking about, or any other neurosurgeon, a young neurosurgeon especially, might be thinking about. So I try my best to bring all those topics in the discussion in the Q&A so that everyone can have a lot of benefit as much as possible as we can get. So I guess it's time to go. Thank you very, very much. The recording will be available on my YouTube channel. Please subscribe to my channel as well, and keep in touch. And I hope it was great to see you all here and great to learn together. It's an amazing opportunity to bring everyone to the same platform from every part of the globe. So again, thank you so much. Please do keep in touch. Keep following the news, social media, and also my WE and CNS joint section on tumors, educational webinars and educational series that you might find very much helpful and very much informative. We are going to conduct a webinar with Professor Michael Sugra, and I believe you will be liking that talk as well. It's a very good one. It's an insightful one, and I hope you guys you're gonna like that. So please to join us for whenever you can. So okay, let's wrap up the session. Time to wrap up the session. Um, I'm going to see you all real soon again on another. There are a few webinars which I have already, I'm trying to schedule them in February, March, and April and May as well. So we got a schedule to, adjust all those dates according to the on-site meetings as well. There are several meetings that have been held on site, and we have to actually, make the schedule according to those meetings as well. So there are a few meetings in line. I haven't finalized the time and the date, but I will, share with you as soon as they get finalized. So, okay, everyone, time to wrap up the session. Thank you very much for joining us today. It was amazing to have you all here with us. So, have a wonderful weekend ahead. Bye.